Welcome to KidzDocTalk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the Director of Telemedicine at Pediatric Associates.
Welcome to KidzDocTalk with Dr. Jennie. Today's guest is Dr. Jonathan Malka discussing food allergies. Dr. Malka is currently the Director of Allergy and Immunology at one of the largest pediatric groups in the country. Prior to starting the allergy division at Pediatric Associates, Dr. Malka was an Assistant Professor of Pediatrics at National Jewish Health Division of Allergy and Immunology and Rheumatology at the University of Colorado Health Science Center. He is currently a Fellow of the American Academy of Pediatrics and the American College of Asthma, Allergy, and Immunology. Dr. Malka's research interests include food allergies, understanding and managing severe asthma, and biomarkers in the diagnosis and management of asthma. Welcome, Dr. Malka.
Hello, Dr. Malka. Welcome back.
Hi, Dr. Berkowitz. How are you? Thanks for having me.
I'm good. So the last time we spoke, which was back in season 1, we talked about allergies, and I asked you a lot of questions, primarily from my own education as a pediatrician, but I have a little bit of a different perspective now because I'm a parent of a child with a lot of food allergies, and this is really new for us to navigate. So I'm hoping to learn a little bit more, I think on the parent side today as we talk about food allergies. So we touched on this briefly last time, but remind me, the most common food allergies that you see primarily are what?
So it has changed a little bit since last season. Before we used to call it top 8 foods. And in children, if we break it down, I think it will be peanut, egg, and milk will be the 3 most common ones in that order. When you have a peanut allergy, peanuts in the legume family. So people get confused with peanut and tree nuts, but they are not the same. When you have a peanut allergy, those patients do have a 30% chance of developing a tree nut allergy. And tree nuts are considered almond, cashew, pistachio, walnut, pecan, and hazelnut. Pine nut, for example, is not considered a tree nut. Coconut, it's not considered a tree nut. So we stick to the almond, cashew, pistachio, walnut, pecan, and hazelnut. Hazelnut being Nutella, right? So it's very commonly ingested. Then the list goes into wheat, soy, then fish and shellfish. Those are the top 8. They added a 9th allergen, which I think to you is dear to your heart now, is sesame seeds. So, and I think, again, it goes back to I think we spoke about the Atopic March last year. Your listeners may or may not remember. I'll be happy to kind of brief you back on it quickly. It's the progression of the allergic disorder over the course of time. Starts with eczema, which makes you prone to having food allergies. Food allergy may not be the cause of the eczema, but eczema is the likely cause of food allergies. Over time, you tend to outgrow some of the foods, which we'll discuss later. And then you develop into the environmental allergies. So those are the atopic march, and then the asthma comes into perspective. Now, I'm mentioning this because sesame seeds have now become more frequent because things are being much more ingested. Foods are being including more sesame in our diet. And it's not because of the Mediterranean diet, right? So we're much more into tahinas or hummus, things that contain sesame, and that becomes more prevalent in our society. Then we're becoming more allergic to it. So that's why it was recently added.
That makes sense. I remember last time saying something like, the one that makes me the most nervous, I think, in the environment, in the community, is peanuts. And you said the one that should make you the most nervous is dairy.
100%, and that still sticks to the same thing. I think the peanut has changed over time because that's the food that we know the most on how to maybe, I don't want to say treat, quote unquote, prevent, maybe decrease severity of reactions. Well, you can do something. We can talk about it later if you want. But in our country, I think that the only deaths that we've seen with food challenges, and it's been 2, and so far than God, has been with milk. And the most common ER visits is actually due to milk. So milk is one of those that is quite a scary food allergen. And we also, I would say, I think in the last year, I think we now say cashew is a new peanut.
Because it's more prevalent?
And severe.
And severe. Okay. Mm-hmm. Wow. So I know when my child was being diagnosed with food allergies, we saw an allergist. There was a lot of, like, the workup was extensive. We had skin testing, we had blood testing. What's the difference, and what's the different utility of the different ways that you guys diagnose food allergies?
So it's a great question. We have to take into account, really be careful with what you wish for sometimes, right? In the testing, because testing food allergies is not what people want to make it to be. All right. And when I give any lectures about food allergies, I always say, guys, the most important component of diagnosing food allergy is three things: history, and more history. And when you think you have enough history, get a little more history, meaning what happened.
Yeah.
Right? So the best diagnostic tool you can have for a clinician is to ask the right questions. As a parent, it is also associate the symptoms with the allergy. And for example, the story of food allergies will be the first, second time you ingest the food, within minutes of the ingestion, you will have a systemic reaction, right? So food is never going to go into your system and just bypass everything, go and give you nasal congestion, or go and give you one little dot in the forehead when there's a rainy day versus a sunny day. It's not going to be associated with autism or behavioral changes or ADHD or developmental disorders. So that's never been associated, and that's a whole different spectrum we should mention about testing and when we get down to it.
Yeah.
So if you have a history that's very consistent with food allergy, like I mentioned, the IgE type of reaction will be first, second time you eat it, within minutes of the ingestion, you will get the hives, the difficulty breathing, lip swelling, cough, wheezing. That then you confirm if it's an allergist, such as myself and my colleagues in the allergy group. You will do a skin test, and the skin test kind of confirms diagnosis, okay? Once you have a confirmation of the history confirmed by the skin test, then you do a blood test. Now, nor the blood test, nor the skin test, nor the reaction will tell you the severity of the potential reaction, which is an important point. The bigger the size of the skin test does not equal a more allergic kid versus a smaller size. The higher the level in the blood test does not equal more allergenic or more allergic response than the lower kid. What the blood test does over time is the higher you have the value, the less likely you're going to outgrow the food. And that goes back to the same atopic march. If you have a high level in blood and you have other allergic conditions, you're then more likely to have a longer duration of your food allergy compared to kids who don't have other allergic conditions. Now, the blood test is also very useful as a way to follow progression of their disease, meaning if I have a high level, but the level goes down over time, and we say if it's a 10-fold decrease over the course of a year or two, that's a child who may be going in the trending of potential outgrowing. So the level of the blood test, especially in children, because the immune system is not fully developed yet, may be low to begin with and then goes high before it goes low again. So you have to be careful. Even though it may be low at the beginning, the kid may be more severely allergic and when actually is becoming very high. So does it not mean that the high one needs an epinephrine versus this one does not need epinephrine? Both of them need epinephrine at any time they're around, and we'll talk about later about treatment.
Yeah.
So to assess, to give you the long answer to your question will be history is the best way. Skin test confirms diagnosis. Blood test is a way to actually follow progression of disease over time. When levels go down, then you will retest and then hopefully food challenge, which is the gold standard. Now, let's say the other side. So a positive test, blood test or skin test equals a 50-50 chance of being true. So what I tell my parents is, my patients, if I toss a quarter, I literally give you the same answer. So what is going to tell me if that quarter is right or wrong is going to be the testing. If you have a test that is positive and the child eats the food, you do not want to take the food away from the patient's diet.
I just want to emphasize that because I think that's really important because people love the testing and you'll have maybe something that turns up positive in the blood, but it's something that the child's been eating without having a reaction. That child is not allergic to the food.
No, that's completely false. And if you actually take it away, and the child's a little one, let's say, and I mentioned earlier on purpose that the immune system is not fully developed. What happens is, if the child's eating the food, and you for some reason you have a concern, and you ask your pediatrician test you, and the pediatrician you finally convince him to test you, you get a positive test of the egg. Let's say the patient is eating the egg. If you take the egg away and the patient has eczema, for example, if you stop the food for 3 weeks or longer, you're likely going to develop the allergy to egg. So stopping the food because of a test where there was no history of reactions before the test, you actually will promote the development of allergies. So it's the test is as good as the history. A positive test without any history of symptoms when ingesting the food, it's not associated with an adverse reaction. It's not a food allergy, nor is associated with an adverse reaction. That's why you go back to the history.
I think that's also really important to call out because I have found that there's an increased popularity with commercial testing? Have you seen these, like,
Yeah,
things
so
that you can buy yourself?
yeah. Sorry. So I was mentioning that. So, the immune system, I wish I had a graph I can show you, but the immune system is the game. I call it the game. So you have different immune globulins, right? Which is kind of what protects you from different viruses and bacteria and proteins that your body has to go through, right? The game stands for IgG, IgA, IgM, and IgE. Okay? So let's say, for example, the IgE, in theory, it's present in our body to protect us from parasites, but we don't have parasites in this country. So, like anything in your body, when you lose balance and you have too much of something, that becomes abnormal, and that abnormal behavior of the IgE is what gives you allergies, right? So we measure IgE as a way to measure allergic response, like I just mentioned, the skin test or the blood test.
Yeah.
So blood tests for food allergies only IgE, right? The higher the level, the more likely you have it if you have a history, but does not mean severity. Now, when you ingest the foods and you tolerate the foods with no consistent reaction to an allergen, meaning the hives, difficulty breathing, shortness of breath, the things we spoke earlier, your body is actually provoking IgG. The IgG in the game is actually the one that makes memory cells. For example, when you give a child vaccines, your body produces IgG to that vaccine, so you're protected against that virus or bacteria you're getting. You give boosters of the vaccine to build that memory. COVID, for example, patients were measuring antibodies. Oh, I had COVID, I want to measure my antibodies. Those are IgG antibodies, right? So again, it's memory. The more you have exposure to it, the higher the level, and it goes down over time if you don't ingest it regularly. Those tests that you're mentioning, those are not standardized testing. That is not covered by insurance, are quite expensive. And what they measure is actually IgG. So that has no role in food allergies. So basically, when you see that, the more you ingest a specific food, the higher the level you'll have. But because your body's making more proteins or having a better response, knowing not to attack that food. So usually the patient comes in with that test is a big list of foods, and I tell them, "Oh, I'm very sorry, you just spent $400, and basically I can tell you what you ate, but does not equal in any way, shape, or form allergies. The opposite to allergy."
Wow. I think that's really important. I hope people listen to that, because I think, and I mean, I can understand as a parent, like you wanting to know, right? Especially if you have maybe other children in the family or other family members who have true food allergies. Right. And when, right, you kind of want to know ahead of time so that way you know what to maybe avoid exposing your child to. But it sounds like that may be detrimental, which I think leads me to my next question of prevention, right? And is there anything that we can do? Because I think the answer used to be no, but now the tide has shifted. Like, is there anything to be done in terms of preventing the development of some food allergies?
Yeah, so that's a great question. The question we get asked the most. And actually, you mentioned something that's quite important. When you have a family member who has a food allergy, those are the ones that should be exposed the most. Yeah. Right? But that's, in reality, the hardest one, because you're afraid of the allergy becoming reactive. Yep. And I think that's also an important concept we have to tackle, right? You have to understand that there's a lot of myths and misconceptions about food allergy, right? The first thing is, being around food allergens, if you don't ingest the food, you will not have a reaction. So anaphylaxis, which is a dreaded reaction, or really a systemic reaction, will only take place if you ingest the food. Contact to the food, as long as it does not contact the mucosa of the mouth, it will just be a local reaction. You can literally, if I touch my arm, I just wipe my arm, wash, soap and water, and it's done, right? Perfect. So if the best thing you can do for a child who's been diagnosed with food allergy, so before you ask how do you prevent, is you should really work on education on what is expected behavior, what is a good fear to have, respect. I call it like the ocean. You want to go in the ocean, but you want to respect it, right? It's because it can be a traitor. The same thing. You want to understand what are your risks and benefits, right? Or the risk and quality of life. I have kids who are so afraid that when they walk the aisle in the supermarket, in the peanut aisle, they hold their breath. That's not a normal response. I understand where they're coming from. Don't get me wrong. I'm not judging or criticizing anyone, but I think if you have the right education, you can prevent those behaviors, because it leads to bullying in school. So we have a lot of bullying in school. So understand the concept of allergy, right? So just being in the environment is not going to give you a reaction, right? So I emphasize that, because if you have another kid, you want to make sure that kid has exposure to the foods. Now, the second sibling does not have to have the same allergen. right? He's more at risk of developing allergies in general. It may present with eczema, it may present with rhinitis, meaning congestion, runny nose, itchy eyes, watery eyes, or asthma. It may present with food allergies. But there's so many allergens you can have reactions to. So likely some of them, if he has a lot of food allergies, will present the same, right? Because how many eggs egg is a common one, you may have egg as well. So in the child who has not been diagnosed, right? And let's say a parent comes to me and I confirm that she's pregnant. I don't messed up, because I got myself burnt in the past. So yes, she's pregnant. So the first thing data has shown that in the third trimester of pregnancy, you can start by adding probiotics to the maternal diet. So the reason why probiotics is useful is because if you give the right microbiome to your child, meaning the right gut flora in a way, and then not only gut flora, the microbiome extends all the way from skin flora to respiratory flora. So the microbiome is actually even more than DNA information that we have. If you have the right microbiome, you're likely going to have more of a barrier effect. So your gut is more mature in a way, it's more tight. It lets less proteins come in that make you more sensitized or prone to becoming allergic, less chances of developing eczema. So if you start with that, and then you go into introduction of foods. Now, let's be clear. What's been the most approved and reproduced study has been the peanut study. And long story short, it's called LEAP. It's learning early about peanut. And they basically did little children who were between 4 and 11 months of age who had moderate eczema and food allergy to egg, because that's an important point. Egg is the most common food associated with eczema, not milk. So changing formulas may not answer your question. So then in those patients who had a little skin test to peanut with no history, so they were sensitized, again, a patient who had no history but it was positive, they went ahead and divided into 2 groups, patients who had peanut, patients who avoided peanut. Long story short, the patients who ate the peanut had a significant less chance of developing food allergies. Mm-hmm. Okay, the study was concluded. A year later, the patients kind of ate peanut as much as they want or didn't want. They challenged again, and they went ahead and had the same protective effect. The recently just published data, actually hasn't been published, was just presented, they call it LEAP Trio. So they follow the same kids, now they're teenagers. And they ate, the group that ate peanut as much as they wanted. The kids who didn't eat peanut, didn't eat it. And still you had the protective effects in the patients who ingested peanut. So what we showed is that if you start early when the immune system is still plastic enough that we can change in our direction, it's not completely mature, as I mentioned earlier, you may protect from early. And as long as you have some exposure to it, that's important. You must continue the exposure. You can have a lifelong immunity or protection from the food allergy. So introduction of the peanut at 4 to 6 months after the baby is able to ingest fruits and vegetables and a motor tone is developed and the feeding part is developed, you want to introduce peanut butter. There's a snack called Bamba, which is like a Cheetos made with peanut. There's some data to suggest that things should be done for eggs, same thing for milk. There's peanut butters, of course, always going to have choking hazards. And there's even data to suggest that if you introduce milk in the first 2 weeks of life, and I'm not discouraging breastfeeding by any way, shape, or form, you supplement milk in the first 2 weeks of life, you may also have a decrease in the incidence of food allergy to milk by 6 months of age. But then the study showed that it's not just the first week or 2 weeks that's important, it's at least drinking 10 mLs for at least 30 days that will protect you for 6 months. So it's not just, he had it one time, nothing happens, he's protected for life. No. If you give the food, continue the ingestion of the food as they go.
That's so interesting. And I actually have a follow-up question just in terms of the milk, because when I think of, giving whole milk to a newborn, obviously that is concerning to me. So that's not necessarily what you're saying. I'm sure there's different recommendations for doing it.
Regular formula. Okay. Not whole milk, because the kidneys are ready for it. Regular formula. Not even hydrolyzed formula, not even the ones that are broken down. You're going to go for intact protein, because that's the only way you're going to promote tolerance, by building the right immune cells, the IgG I mentioned earlier.
That's fascinating, because I always thought of one of the things that breastfeeding protects against was the development of food allergies. That's what was like one of the protective factors. I'm
still a board certified pediatrician. I'm still keeping my certification, but that statement has never been actually proven.
Oh, wow. Okay.
Breastfeeding is amazing. I'm not discouraging you. You should always breastfeed. But as a protective effect for food allergies, there's no significant data to say that has been shown. But can it be, would I say stop it? No. I'll continue. We just got to think about maybe supplementing, and it's not going to stop your breastfeeding. It's a very small amount, but you want to supplement and keep it there from the get-go. Especially, again, it's not for everyone. It's not for every patient who walks into your house, not for every mother listening to the podcast. It's for those patients who have family risk factors or have someone else with food allergies. You want to be proactive to minimize the reaction of that other patient. And it's important to understand one thing. A lot of parents are concerned, oh, what if he has a reaction? Yes, that's a good point. But let's go back to the term I've used a lot today. The immune system is not fully developed, right? So the reaction at the first exposure in children is actually very mild. Tends to be just hives. Mm-hmm. And if you ask the question, majority of parents, what they do when they get the reaction is, oh, I just gave him a bath. That, to my knowledge, water is not cure, although water is great. But what I'm trying to say is things will tend to go away on their own because it's a mild reaction, because your body's still not fully blown up in a mature immune system, right? So that's why when you get risk benefit, you're better off by introducing than not, because the reaction will not be a life-threatening anaphylactic reaction.
Follow, but I also don't want people to necessarily introduce the food, see the reaction, be like, okay, now they're having a reaction, I guess they're allergic. That's also not the correct conclusion, right? That's when we really want to get an allergist involved to add that supplemental piece to the puzzle of the skin testing and the blood testing to actually confirm whether or not this is a true allergy.
Yes, because now we have a lot of different approaches, right? We have something called oral immunotherapy. We have what's called the egg and the milk ladder, which sometimes we're given baked forms and we kind of let them, step up in a way to get them. So there are many, many new ways. But still, data's a little conflicting. But there we can, if you're the right patient, you can start early, and we can hopefully kind of skew this reaction from developing all the way, or at least halting the progression of the food allergy over time and outgrowing it, a little faster. Now, let's talk about outgrowing for a second, right? Because that can make a big difference. So, milk and egg tends to be outgrown at least 80% by 6 years of age. So it's very commonly outgrown, right? So one important point, for example, if your kids are allergic to milk or egg, but is eating things that are baked with milk and egg, don't stop it. Because in a way, you actually are giving some form of the protein, right? So it doesn't translate, but you want to do, for example, maybe the egg, you don't want to do mayonnaise, meringue, ranch dressing, things that may contain eggs, some ice creams. If they're not baked, they're not going to be allergenic. The peanut is outgrown only 20% of the patients, and that's where the blood test becomes a useful tool, right? The tree nut's only about 10% or less. Fish and shellfish less. Sesame will be considered in the tree nut family, so each of those foods seems to be then longer, right? So that's why if you're early and we can do something about it, with most of the foods we can nowadays, you have a better chance of at least not having a severe reaction and potentially accelerating the outgrowing of the food allergy.
So that makes sense to me, because I remember going for the oral challenge. My son had an oral challenge because his testing was inconclusive for peanut allergy. He had a bunch of confirmed food allergies, but the one that I think didn't make a lot of sense looking at the blood work was peanuts. So our allergist recommended an oral challenge, and we needed to schedule it kind of urgently because he was about to turn 1. And I remember that was an important piece that, like you were saying, we really needed to do it sooner rather than later, because we wanted to sort of continue that exposure if he was not in fact allergic, which he's not. So now we kind of have like a prescription of how often we have to give him peanuts.
Right. And there are different forms nowadays, and we convert the amount of proteins you give. And once you have it, we can do it maybe a couple times a week. You don't have to do it every day like a religious thing, but just keep in their diet, and you're likely not going to grow it, because if you didn't, he potentially will have the food allergy to peanut.
So now let's talk about treatment, because I think we have a nice overview of like what to expect and what to look for. So let's talk about treatment, because I know this also is like an exciting kind of development in the field, and there's new ones coming out regularly.
Right. So there is there is the one biological. So it was one laboratory that made peanut protein. It's called Palforzia. It's quite expensive, and it's really hard to do, in the sense that it's too little amount of protein and too expensive. And we have a lot of different ways that we can do it, which is significantly cheaper for the families and easier to do. So Palforzia was done in patients is used, or what's called oral immunotherapy. I mentioned this earlier. So oral immunotherapy are patients who already have developed the food allergy, and now we're trying to protect them from a severe reaction. Now, it's a big difference, because a lot of patients believe that OIT, which is oral immunotherapy, is going to make you outgrow the food allergy, and that is not the reason why you should do it, because it may not actually work that way. It's actually never been shown. So OIT goes back to when you can do it, right? So I mentioned earlier that if you start early, like the LEAP study, and you keep, you're going to have even if you don't eat every day, you're going to have lifelong protection. In the oral immunotherapy, once you stop, you may go back to square one. So oral immunotherapy is a very labor-intensive procedure that has to come into the office every 2 weeks. We give increasing amounts of the protein. We start very little dose. The kid goes home with the parent, and he eats it every single day. And then in 2 weeks after, comes to the office, and we reach a dose that we believe to be a maintenance dose. And that, for example, for peanut is about 2 grams of peanut protein. I'm sorry. It varies depending on the different foods, so you have a different amount of proteins. Then you follow the blood test over time. So you do like a blood test before, a blood test in the middle, a blood test a year after. If the level's looking good, that he's a good responder, you start to go down. Now, those patients are just able to tolerate the food or small amounts of the food, but at the moment they stop, if they have not outgrown it, after a few months, they're going to go back to square one. That approach also for babies may be actually much more beneficial, because in babies, when you start doing that, because again, the immune system is not fully developed, we actually teach them. And then those patients tend to outgrow it much quicker. So that's the biggest now, the most common one. It's been there's more data now. There's some, I'm personally doing for peanut, for cashew, sesame, and egg. I'm avoiding milk because it's quite dangerous, like we mentioned earlier. There's no really good data for fish and shellfish. There is for wheat. So for the common ones, you can do it. There is something called the egg ladder and the milk ladder. So some patients don't have to go to the burdensome of doing OIT, but they can do like very baked products, or they can even do lightly baked products, but they just can't do the egg, for example. So we kind of step them up in baked forms, and they can do it at home or in the office, and they do it every day. And then over time, we follow the progression. Those are kids who tend to outgrow it. For some children, it's not worth it to do anything, and really time's of the essence. You just follow over time, and they'll outgrow on their own. And some kids will outgrow between 3 and 4 years before the 6-year cutoff. So some parents, I tell them, look, I think you're a kid you don't have any risk factors, your levels are low. I tested it twice, and in 2 different points in time, and they're low. Let's not go crazy and bring you here every 2 weeks. I think just give it time, and by the time I confirm it, then I bring them in, do a food challenge. So that is kind of the approach once you have a diagnosis. Now, for the patients who are not diagnosed yet, or we want to prevent, we then have discussion we had before about their introduction and make sure they continue. If they have a reaction, then they will shift to the other group and become now the patients who are going to be treated. But we already have a base that they can eat some amount.
How do you decide who's a good candidate for OIT?
So that's a great question. I think first of all is parents' commitment, right? So I think it's a parent who is willing to do it, because it's quite labor intensive. It's every single day. There's a lot of restrictions when you do OIT. You cannot exercise for 2 hours after ingesting the food, because body temperatures will change the dose, right? Reaction to the dose. So for example, one day I ate one peanut M&M, the next day I ate it and I exercised, I may have a reaction. Even shown that maybe menstrual periods, right? If you have your period, your body temperature goes up, you may have actually the same changes in doses. So teenagers are quite hard to do, because I think they're very compliant and they have such a lifestyle that they're not going to be taken every day, and they get tired of doing it. So I personally, and a lot of allergists out there do, I personally don't start teenagers unless there's a really commitment, or if they have the kids who are at high risk, who has had reactions and needing epinephrine a few times. Those are kids that I will have a discussion. I may not go all the way out to the maintenance dose. I may go to a lower dose that may protect them from accidental injection. I may, if a patient has bad eczema or bad asthma, those are patients who are at risk of asthma. If you have a reaction, you're more likely to have a more severe reaction. If the patient's compliance, meaning his follow-up and clinics are not good, it comes once every few years and wants to do OIT, those are patients going to even likely fail, because the likelihood of failing OIT is when you start skipping doses. If you skip a dose and then you go back to eating, it's fine, I'll eat the next day. Or if you exercise, or if you have a fever, you got to change. If you have a dental procedure, because there's an open now wound, direct exposure, and more penetrance, right? Yeah. So there is a lot of caveats, right, to do it, and that's why I personally believe that little children are easier to do, because parents are still managing them. I think you can control them. Don't exercise for 2 hours, and I think also they have a greater chance of outgrowing the allergy, right? So I think it's a win-win for them. to make a commitment for a kid who's not going to be eating, or stopping at some point. I'm now doing like an 8-year-old who has a lot of food allergies, and we decided that the mom wanted to do some foods because he needs some foods in his diet. So we added almond, and we're now doing sesame seeds. So it's 2 foods. We may do one more at the end if everything goes well with the second one, as a way to just give him something. But he still got to carry his Epipen. He still has to carry everything else. He doesn't have any other comorbid condition like asthma, allergies, or eczema. So it's a kid who's not such a risk, just many food allergies.
So I actually want to wrap up by talking about the EpiPen, which has come up a lot in this conversation. I think it'd be irresponsible for us to have a whole conversation about food allergies and not mention anaphylaxis and not mention the utility of the EpiPen. So what is anaphylaxis, and why should everyone with a food allergy, or really any kind of allergy, have an EpiPen?
So in a food I mentioned earlier that we don't have a way to know the severity, right? So I keep giving the example always to my parents is, well, when you drive, you wear the seatbelt, right? Why? Because you may get into just a little bumper, fender, or you may get up to a full-blown accident, right? God forbid that happens. If that happens, you have the protection of the seatbelt. So you don't want if you leave your cell phone at home, you're likely going to be nervous, and you're likely going to go back home and get it, right? Because it's other than playing, distracting the kids, it's a useful tool to communicate, right? So that you kind of have to think the same way for the EpiPen. Any adverse reaction to a food is an EpiPen potential reaction. Any food allergy. Data shows that if you delay the use of the epinephrine, you're likely going to have a much more severe reaction. So in theory, and if I were to go to court and raise my right hand, I have to say the only approved treatment for food allergy is an epinephrine. Zyrtec, nor Benadryl, nor antihistamines, Claritin, are approved treatment. Let me dwell on that for a second.
Yeah.
I would really recommend against Benadryl.
I remember this from last time, and I want you to know that I learned from you, and now I actually had to give my son something recently because he had a reaction that we would not expect, and I went straight for the Zyrtec, so I want you to be proud of me.
Yes, thank you, Jen. I appreciate it. Why? If you're gonna get me a car, don't get me a car from 2001. Get me a 2024 car, right? So you're not going to, it's Benadryl is like Tupperware. It's just a brand. It's not the approved. It's not better than anything else. Liquid antihistamines will work as well as any liquid antihistamine. And if you have a kid who can communicate with you, why knock him out? You want to actually be able to communicate with the provider and the patient to know how he's doing. So forget Benadryl. That's an old.
And I would say even in a nonverbal kid, right, you don't want to knock him out because sometimes that could be confusing the picture, right? Because you could be getting sleepy or altered as a result of your anaphylaxis. And if you're doing that because of the Benadryl, now we don't know what's happening. So, so second generation, I think the point you made last time, which is important, second generation antihistamines like cetirizine, which is the generic for Zyrtec, do not cross the blood-brain barrier as much. And so we don't see that same the CNS depression, right, or that same sort of depressive symptoms,
sleepiness or
sleepiness. Yeah.
So now, with that said, even a second generation is not the approved treatment.
Mm-hmm.
So I always tell parents, look, no one can judge you, no one can say we're wrong if you gave the epinephrine. So the right approach should be first sign of a reaction to a food. And that again, the signs can be subtle. The little baby can just start going like this, and that can be that having some difficulty swallowing. Why wait?
Yeah.
Right. So the first sign of a reaction, if you know as the ingesting of the food, the right approach should be epinephrine, Zyrtec, and if asthmatic, I will give albuterol. Now the old data says you have to go to the ER. Look, if you do that approach and the kid's doing fine, you really don't have to go to the ER. Especially when you have telemedicine available nowadays, you can just follow up with them, and those patients are likely going to be fine. You get a refill, you're good to go. If that same patient, for example, has an improvement, but within 5-10 minutes kind of gets worse, then you give the second epi, and then 911. If that same patient, you give the epi, you give the Zyrtec, didn't get better within 5 minutes, you give the second epi, and you call 911. So an important thing is you must carry the epinephrine or injector. They come together for a reason. It's not one for me, one for mom, one for me, one for grandma, one for me, one for school. It's 2 for me, 2 for school. I know they're expensive, but you must carry the 2 of them together because there's a 20% chance of needing the second epinephrine. If you misfire the first one, you're going to have an issue if you don't have the second one. So, again, if you buy a car, you're going to buy a car with seatbelt and airbag, right? So, same thing. Now, some parents ask me, well, what if one little hive here and there? If you just hive and you're not sure if you ate the food, fine, you can do Zyrtec. But as long as you start having any other symptoms, you have concern, or your maternal instinct or paternal instinct for that matter, gives you have any doubt or starts coughing or just like even scratching his tongue, just go for the epinephrine. There is no harm if you gave it. There will be significantly more harm if you didn't give it or delay the use of it. And that's the key point. It's the use of it. It's not going to harm your child. Yes, you may have nightmares from the scare you had injecting your kid, but it's a very easy pen to use. Just be trained how to use it. Be retrained every so often when you see a pediatrician or allergist, and always carry with you at all times and use it when it's there for a reason.
No one ever regrets giving the epi, right? Unfortunately, people regret not giving it.
100%. Yes. Yeah. Yes. So that's true about approach for anaphylaxis. Anaphylaxis will be when you have more than two system organs involved. And likely involves if you have the hives, the vomiting, and respiratory distress. Sometimes you get hypotensive, blood pressure drops. So that's a full-blown anaphylaxis, right? But anaphylaxis, although it's the most dreaded one, is not the most common one. Thank God. So understand that you can prevent it, hopefully by doing early in treatment, but it's not the most common reaction. It can happen 100%, but it's not the most common one.
Most common reactions being, I'm assuming rash. That's probably the one.
Rash, it could be vomiting. Vomiting in a way is a good thing because your body's kind of releasing that, getting rid of the protein. So in a way, that's a good thing. Sometimes cough or wheezing or asthma flares can also be the cause.
Yeah, makes sense. Makes sense. Okay. All right. We covered a lot of ground today. Anything to wrap up? Any major things that you want to make sure we take away that families with kids with food allergies really take away?
Yeah. So I think we touched on a few things. I think the first thing is just testing based on history. Don't just look for allergies as a way to explain everything, because allergies are not going to explain everything. Not every nasal congestion is a food allergy. If you have families with kids with food allergies, education for your patient, it's for the patient allergic to it, it's the best thing, not to grab food from others' plate. Medical bracelets, training your kid to ask questions and to read labels. And so therefore you don't have to avoid the other ones in the family. And, also giving confidence that you can be around it, because that's actually will improve quality of life. To always carry the epinephrine together everywhere, every day. That not to be afraid of using it. Like you said, no one will regret using it or regret not using it. Forget the use of Benadryl, think of Zyrtec. And if you have one positive test, you were diagnosed with food allergy, doesn't mean you're stuck for life. Follow up the blood test. Like I tell the pediatrician sometimes, is like, if you go to physical every year, you have food allergy, doing the physical, you can get a blood test again. And that's a good way of following the progression of your disease. And if it goes down, then that's a good time for the allergist to come back and do some, the role in the management. So I think that would be kind of my conclusion for season 2 for now.
Okay. All right. Fantastic. Well, thank you so much. Thank you again for coming back and for discussing this really important topic.
Thanks for having me anytime. Thank you, Jen. Be well.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on KidzDocTalk.